All right, welcome to the digestive system, please. I want you to pay attention in every single word I'm going to go. We have a short time. We are going to cover it, and we can actually review one or more of these topics at the end. Okay, so let's start. Just a moment. Okay. All right, so let's start. So here we have the gastrointestinal system. So please, we have the gastrointestinal system, and that is part of review of bioscience, okay? Intestinal system. System, I say system. All right, system is not the same to say tract. So because the other one, the classification of the gastrointestinal system will be in the gastrointestinal tract. Tract is different from system, okay? All right, and is divided in what? In the accessory organs. Accessory organs. So please, this is very important. There is many questions coming about this, so you need to be very careful with the classification. The GI tract means tube. Tract with tube. All the tubing of the GI system is called the GI tract. We okay with that? The GI tract will be divided into upper GI tract, and this is so important. Upper GI tract. I didn't say upper GI system. I say upper GI tract. And the other one will be, if we have an upper, we are going to have a lower GI tract. You okay? You follow me, please?
Yes.
Okay, perfect.
Yes.
Your participation is important always. Please, thank you. Upper GI tract will be from the oropharynx, go to all the oral cavity, all the esophagus, all the stomach, and they're going to go end into the duodenum, the duodenum. So that is the upper GI tract. This is huge, important. It's going to save you so much time, okay, in the future. Now, from the lower GI tract, we have the jejunum, from the jejunum, and they go to the rectum, anus, anus. Okay? So that is the upper and the lower GI tract. Okay? So tell me one thing. When you eat, somebody eat blood here? Do you eat blood?
Yeah,
Yes.
that's my dessert.
You deserve eggs. Oh my God.
Dinuguan.
Especially at
Yeah,
night, right? Like
beef.
like Dracula. No,
Chocolate meat.
Yes. Chocolate meat. Yes, Tom.
yeah. All
That's
right.
my favorite.
Chocolate meat.
On rice.
Oh, okay. So what about everybody's eating blood? What about the use of the steak? What is the use of the steak?
It
Is
has blood.
is blood or no?
Yes.
Yes.
Right, it's blood. Excellent, yeah. But there is a other in Philippines, I guess. In my country, there is we eat the blood of the. Well, I don't eat. I changed my habits too, but before it was for me delicious. Is the blood of the pork or the blood of the chicken? They fry it and they put some kind of onions, some spices here, and with very crunchy bread, delicious with the coffee, right? So
Anticuchos.
anticuchos is heart of the cow. That is another delicatessen, so super delicious. But tell me one thing: when you cook the blood, what color is the blood?
Black.
Black, right? Very good. It's black, 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 black. So this black blood is because why is it going to become black? Because the blood with when you are bleeding, listen, when you are bleeding in the stomach or in the duodenum, the blood is going to be mixed with the gastric acid, and the gastric acid literally is going to cook the bleeding, the blood that is in the stomach. So as a resultant, they are going to lead into a black material, black stool. So when you are going to do poo-poo, when you go to the bathroom, your poo, your fecal material is going to be black, totally black. And why is important to know that? Because you can identify where is the bleeding in this patient. So there is blood in the stools. So where is coming from that blood? That blood coming from the upper or the lower GI tract. If there is black as a tar. So look at this. Do you see, for example, what color is this? What color is that? Black.
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 So you don't have doubt that is black. When you said, "Oh, that stool looks like black," that is not black. The reaction of the person when they see a black stool, like a tar stool, like very black, is immediate reaction. Oh, black. That is actually actually what we call black stool, and that name is called what we call is the melena. Bleeding in the upper GI tract are going to lead into melena. So you need to remember that name, melena. Okay? Melena is the presence of blood of bleeding in the GI tract. If you have some ulcers in the esophagus, or you have some ulcers in the stomach, or actually you are bleeding in the mouth and you are swallowing blood, your own blood, that is going to be cooked, and the stools are going to be black. You okay with that?
Yes.
Okay. So if what happening is the bleeding is below the duodenum and beyond the duodenum is the jejunum and ileum. In this case, please, the gastric acid was already neutralized. Based on bioscience, you know that in the duodenum, what is coming? Is coming the gastric acid with a pH 2, the pancreatic juice with pH 12. I told you before, remember that, right? So we are actually, we are going to use that now. So we have the gallbladder, the chyme is going to come with the food with pH 2, and the pancreatic juice is going to be pH 12. Acid to alkaline 12. Together neutralized. So the blood that is in the lower GI tract will not have that effect of the gastric acid because already is neutralized by the pancreatic juice. So in that case, the if you are still bleeding in the lower GI tract, that is going to be a very dark brown. Very dark brown, close to black, but is not black. It's dark brown. And that is called the hematochezia. Hematochezia. No. Hematochezia. Okay? Hematochezia. So there's two terms that you already know. Melena, upper GI tract, hematochezia, lower GI tract. Is that clear?
Yes.
Yes, Doc.
Yes.
Okay,
Yes.
perfect. All right. So just remember, that is important that you need to know where the bleeding is coming from. So you're bleeding, but you don't know where it's coming from. So you need to know that. Now, some people, when they do stools, they are going to have bleeding that is very red. So this is very black, melena, black. We have brown, dark brown hematochezia, And we have, when they are bleeding from the rectum or the colon sigmoids, they are going to be very bright bleeding, bright red bleeding. Why is that? Why? Because the closer the bleeding is coming close to the anus, the key word is to think about how much time is being exposed by the enzymes of the GI tract. So if the bleeding is close to the anus, there is no too much time, there is no too much contact with enzymes, so the blood will not be cooked. So the more closer to the anus, that is going to be more reddish, the bleeding. Example, hemorrhoids. Do you know somebody with hemorrhoids? Or do you hear about somebody with hemorrhoids, patients, right?
Yes.
Hemorrhoids, right?
Yes.
Right. So these hemorrhoids are going to be a dilation of the rectal veins that when they are dilated are called the hemorrhoids. And they can be ruptured, especially when you are pushing too hard, especially those rupture happen in patients with constipation. They push, the hemorrhoids blow up and that produce bleeding and a lot of pain. Okay, so the closer to the GI, to the anus is going to be red. So in the lower GI tract will be hematochezia. In the upper GI tract will be melena. Be okay with that? Is that clear?
Yes.
Yes.
Okay. So now the accessory organs. The accessory organs, what? The accessory organs are going to be the teeth. Teeth are accessory organs. What else? The tongue. The tongue is accessory organ. We have the salivary glands. Salivary glands are accessory organ. What else? The liver, the pancreas, the gallbladder. That is kind of a review. We already talked about that. So accessory organs. So you need to remember what are the accessory organs. Think about your teeth. Think about your tongue. Think about your saliva. What about if you don't have teeth? What about if you don't have tongue? What happens if you don't have saliva? What happens if, if the liver is not working properly? What happens if the pancreas is not working properly? Gallbladder, what is the function of all these guys? Okay, all right. So now, you know the teeth. The teeth, basically, what I want to remark here is the teeth is going to be problems with aging process, right? So all these gastrointestinal system, we need each of those components, each of them, all of them need to work properly. Why? Because what is the result of to have a dysfunctional gastrointestinal system is going to be malnourishment. Malnourishment. Every single organ that we have in the GI system is needed for a good absorption and a good nutrition at the end. Okay? Teeth, for example, people who are elderly, they cannot chew it. If they cannot chew it, they can have big pieces and they can choke and they can die because of suffocation, right? Tongue, can you eat without moving your tongue? Tell me. Can
No.
you eat? Can you eat without moving your tongue? No, right? So what is the function of the tongue? By the way, you know how many muscles we have in the tongue? We have 15 muscles. 1-5. It's a lot, right? It's a lot. There are some variations here and there, but okay. 15 average. 15 average. And the tongue, why do we need the tongue? Why do we need the tongue? Please.
Swallow, to
To
talk,
lick. To
To
lick.
swallow. What else?
to talk,
To
to
mix.
talk.
To
To
talk.
mix the food.
So the tongue, what is doing, if you eat, try to eat without moving the tongue. It's not possible. Yeah, probably you can do it, but you cannot swallow. So the tongue is used for swallowing. Second, very important, that the food is going to be mixed with the saliva. It's a mixer. So the tongue is going to be mixing the food with the saliva. Saliva have a very important component. Saliva you know that is composed by the amylase. And I'm talking about more comfortable about amylase because you know what is amylase. This is not the first time you see it, so you pass bioscience. Amylase, amylase and water and electrolytes. That is what is the saliva. Saliva, water, electrolytes, and amylase. Electrolyte, water, and amylase. What is doing the amylase? Just, uh, I will tell you, amylase is going to be the enzyme who digests carbohydrates. As a courtesy, that's what I was trying to find that word. Amylase is going to be digesting the carbohydrates. Carbohydrates. What does it mean, digestion? Somebody please, with one word. What does it mean, digestion? Tell me, explain me what is digestion. One or two words.
Digest.
Huh?
Process.
Process, okay, keep going.
Breakdown.
To
Who said breakdown?
digest.
Who
To
said
digest.
breakdown? Who said breakdown?
Breakdown.
Erica.
Erica, very good. Breaking down, that is digestion. Please, if somebody have digestion, oh, food, meal, that's all what you have, what we have in our mind, that is wrong. No, it's all right, but this is not enough. You need to know the definition of digestion. You have mild indigestion. You have not a good digestion. What does it mean? You're a nurse, you're in the medical field. Somebody's asking, what is digestion? It's the basic thing we need to know. Digestion means breaking down, breaking down, breaking down, breaking down, breaking down. Digestion means breaking down. And why do we need to break down the food? Somebody can tell me. So why we need to break it down?
To absorb nutrients.
Exactly. We need to break it down in small pieces, in small molecules. Digestion is breaking down the food into chunks, big chunks. That is, you start the digestion with the mouth, with your teeth. You're breaking. So why do we have teeth? In this class, you need to know why is everything. Why? Okay? Critical thinking. So the digestion starts in the mouth. And this is a mechanical digestion because you are breaking down the food with your teeth. Second, we have the chemical digestion. Is everything writing? It's the chemical digestion in the mouth. Why? Because the saliva is going to break down, digest the carbohydrates, for example. And again, we talk about in bioscience again. I'm sorry to tell that, but it's the truth. That is that I ask you, the water and the carbohydrates are going to produce the breaking down of the carbohydrates. Example, go to your kitchen. Remember that example I gave you. Go to your kitchen, open the sink, put water in the sink, and put a piece of bread in the sink. Come back in 5 minutes. What happened with the bread? The bread is totally being dissolved, yes or no?
Yes.
So
Yes.
that is what we call hydrolysis. Hydrolysis. Hydro, water, lysis, breaking down. So the water is going to break down the bread, the starch in pieces. That is what happened in your mouth because your saliva have, in addition, have amylase, they have water, and that contact will make the carbohydrates dissolve. Homework. I'm going to give you homework. I want you to go, if you have a beer at home, take a beer. Put just one sip of beer in your mouth. Sip of beer in your mouth and leave it there for a few seconds, 1 minute. You will know that the beer start to change taste. They become sweet after 1 minute without moving your mouth. Just leave it there in your mouth. It's going to be, in 1 minute, it's going to be sweet. That is magic? No, it's not magic. Because you know the beer have the disaccharide, that is the maltose. And when you break it down, the maltose is going to give you two glucose, and glucose is sweet. So who is doing that breakdown? The water of the saliva. You okay with that?
Yes.
Okay. All right. So now, all right. So that is the teeth. We need is a mechanical digestion. So digestion. Tongue is going to mix the saliva much better, the saliva with the food. So it's a good deal to have a tongue, right? A tongue is going to make you swallow. It's going to make you talk. It's going to. It's a mixer. The tongue is a mixer. Salivary glands, you already know, they're going to be the chemical digestion. So we have chemical and mechanical digestion. Mechanical is when you crash, and chemical is when you have these enzymes acting into, or the water acting into the nutrients. The liver, the liver. In the liver, what is going to happen is the liver we have is the big factory is the big factory. The liver is the big factory. Why? Because the liver is going to have 200, 210, no, what 210? It's too low. 510, 510 functions. 510 functions. 510 functions. And these 500, I want you to remember how many? 4. What is the first one I ask you to remember? What is the first function of the liver?
Fibrin.
Albumin.
Albumin, 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 albumin. So please, I'm going to ask this very bad. So I've been repeating like 10 times already. I need to stick that in your mind. The liver is going to produce albumin. Why is important that? Because you, please, I'm telling you, when I say something is because you're going to use by sure in the future, in this quiz, in the midterm, the final, well, the midterm final. Albumin. So somebody remember that I was telling you albumin attract water? Yes or no?
Yes.
Yes.
That is important because if you are malnourished, you don't have albumin or low albumin. So albumin cannot retain the water in the vascular space. So what happened? Fluid start to escape and you have edemas. 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 So other things, you can pee proteins in some situations like a preeclampsia. Probably you're familiar with that. It probably is too much, but preeclampsia is the hypertension during the pregnancy, and you start to pee a lot of proteins, so you start to get swollen because you are losing proteins. Okay, albumin. Who produces the albumin? All the cells in the body, but the majority of the albumin is going to be present in the liver. In the liver. We okay with that?
Yes.
So the whole blood, 4 or 5 liters are going to contain about 200 grams of albumin. Yeah, it's a lot of albumin we have in our body. And albumin is, besides that, is the taxi driver. Is the taxi driver for everything that you put it in your blood. For example, if you eat carbohydrates or you eat fat or you eat some proteins, those proteins are going to be absorbed as monomers. Carbohydrates as a monosaccharide, the lipids as fatty acids, and the what? And the proteins as amino acids. All these, when they are being absorbed by the intestine, they go to the bloodstream. But in the bloodstream, they need to be transported in a taxi driver. All of them, no exemption. All of them, they need to be in order to go to be distributed in the body. They need to call a taxi. So fat, go to the blood. Amino acids, go to the blood. Carbohydrates, monosaccharide, go to the blood. Taxi driver, taxi, please. Who is coming? The albumin. And the albumin is going to transport wherever they need to go. Okay? The albumin. What is the second function of the liver?
Bile.
Bile. Bile. Be bile. Bile, so please don't think about bile is the bilirubin. So again, please don't refuse to learn. Bilirubin is not the bile. Bilirubin is part of the bile. Bile is the bartender. I mean, the liver is the bartender. So go to the bartender. What drink you want to drink? Bile. Okay, so the bartender, the liver, is going to take the bilirubin, water, electrolytes, cholesterol, lecithin, bile acids, bilirubin, I told you already, together and shake it out. And that is your cocktail called bile. So bile is not bilirubin. Bilirubin is part of the bile. Who produced the bile? The bartender. Who is the bartender? The liver. And when the liver, when the bartender is going to serve you in a glass, that glass is the gallbladder. You okay with that?
Yes.
Yes.
What is the other function of the liver?
Coagulation factors.
Coagulation.
Beautiful. The coagulation factors. The coagulation factors are going to produce at the end which protein?
Fibrin.
Fibrin. So everybody must know that, please. Okay. So, all right. So, okay. So I'm telling you. Okay. So fibrin. The fibrin is part of the secondary hemostasia. Yes or no?
Yes.
That's correct. So and that is going to be part of the coagulation process. Very good. And D, what is D?
Detoxification.
The detoxification, right? Talking about that detoxification, the best example you can think about is the ammonia. Ammonia are going to be captured by the liver, and the liver are going to transform that ammonia into urea. Yes or no?
Yes.
Everybody got that?
Yes.
So tell me, if everybody got that, tell me where is coming from the ammonia?
The protein metabolized.
Beautiful, excellent. The metabolism of the proteins. Tell me, can you store proteins? Yes or no?
No.
No.
No,
No.
excellent. Bioscience, beautiful. You don't store proteins. So that means I'm going to eat meat for 3 days in order to have proteins for the rest of the year. I cannot do that. You need to eat proteins every single day. Why? Because you don't store the proteins. You okay with that? When you don't, what is happening with that excess of proteins? If you eat too much proteins, that the proteins, the body is going to take only the amino acids that are required for that day. But if you're taking excess, those proteins, they need to be eliminated. And how they are going to eliminate that excess of proteins? They are going to break down the amino acid. So they break down the amino acid, and the group amino are going to combine with the water in the blood, producing ammonia. But the ammonia is too toxic, extremely toxic. So the ammonia is going to be taken by the liver, and the liver is going to transform the ammonia into something less toxic. That is the urea. And the urea then is eliminated by the kidney. So when you go to the bathroom, gas station, 2-3 days, homework, go to gas stations that they are not clean in 2-3 days, smell. That smell is the urea. Okay? That is the urea smell. The cats, for example, they have a strong pee. Why they have a strong pee? Because the cats, they eat only proteins. They don't eat lettuce, broccoli. Give me mango. Give me watermelon, or give me an orange. The cats don't eat meat, so they always have excess of proteins. So that's why they are going to have very much a lot of urea. Are you okay with that?
Yes.
All right, so talking about the gastrointestinal system, you need to remember the liver, they have these main 4 functions. There's many others, but they're going to be A, B, C, and D. A, B, C, and D. So important. Look at this. I have a patient. You have a patient. You have a patient who have liver failure. liver failure. Oh, A, B, C, D. Oh, A, albumin. What is the levels of albumin? They have edemas or no? B, oh, the bile, the liver is not taking the bilirubin to produce the bile. So there's jaundice or no? Jaundice or no? So I need to check the mucus, is there yellow, the skin of the whatever. C, oh, coagulation, liver is failing. Oh, I need to check the bleeding. I going to check bruises, bleeding on the gums, right? Oh, the patient is having liver failure, the ammonia. Oh, we need too much protein. So what we need to do? We need to decrease the ingestion of proteins because the liver is not working properly. And for that, ammonia, when they reach the central nervous system, you have LOC. You know what is LOC, right? LOC? Somebody
Level
know?
of consciousness.
Level of consciousness. The patient start get confused because the ammonia is very toxic. They go to the brain and they can produce even coma and death. See? And that is with your nursing process. You go to the clinical history, present, past, then you go to the laboratory tests if that is required. So that's what is your mental exercise. So if you don't do that, you're going to have a lot of mistakes. And you know what? The worst for me is that somebody is going to tell you what to do. And we are going to just be like that. Or I don't know because nobody told me what to do. You're a leadership. You're a leader in your community. So you need to take the role. If you are prepared for that role, take it. If not, just wait somebody tell you what to do. Okay? All right? We got it? Hello?
Yes.
Yes.
Okay. All right, so let's talk about the pancreas. Pancreas is a mixed gland. What is a mixed gland?
Endocrine and exocrine.
Endocrine and exocrine. Excellent. The endocrine is the insulin, the glucagon, and the somatostatin, right? I remember the quiz from bioscience. Okay, endocrine. And you know what is the difference between endocrine and exocrine? We talk even in class 2, right? In anatomy physiology. Exocrine means that they're going to have a duct. So if this is the pancreas, the pancreas is going to have a duct. This duct is, I'm going to exaggerate a little bit. Here we have this, imagine like it's a river. And the river have some branches of small rivers that are coming into the main stream. So this is the formation of the pancreatic juice. These pancreatic juice, they are going to, these are glands. These glands are going to drain the pancreatic juice in the pancreatic duct. Or called the Wilson's duct. So that is the collection of the pancreatic juice. Pancreatic juice pH 12. Okay? All right, so pancreatic juice, we are going to see what are the components. Everything is written, so I'm going to go over very soon. It's basically amylase, protease, and lipase. Bicarbonate, water, electrolytes. So basically, those are the components of pancreatic juice. The gallbladder, what is the function of the gallbladder? Tell me, the gallbladder produce bile, yes or no?
No, it stores the bile.
It stores bile.
It stores the bile. So, all right, so another thing is don't get confused that the production means the secretion. No, production is the liver. Who produce the bile is the liver, the bartender. And the gallbladder is the glass where it's going to put the bile. You okay with that? And that means that the gallbladder is only a storage. There is other functions, concentration, whatever. It's not needed. But basically it's going to be the storage of the bile. You okay?
Yes.
Okay, perfect. So that is the introduction about the gastrointestinal. All right. So here we have the functions of the GI tract. All these cogwheels that you see there basically are the open eyes, open ears. We have digestion, absorption, and elimination. Now let's go. What is digestion? What is digestion? Everybody, please collaborate. Digestion, breaking down. Breaking down. Excellent. And then the breaking down is needed in order to make the molecule, the diet, the nutrient be small enough to be absorbed. You cannot absorb a piece of chicken. You cannot absorb a chunk of a New York steak like it is. You cannot, because they need to pass through the cells. And in order to happen that, they need to break it down at the level of molecules. Tiny, tiny. You start to break it down from the mouth, saliva, then the stomach, and then they're going to be absorbed in the intestine, small intestine. Okay, we will talk about bit by bit. So absorption of the nutrients. What is the membrane transportation that mostly happen in the absorption of nutrients? Bioscience.
Facilitated.
Excellent. And actually happen. We're talking anatomy, physiology. So it's the third time we're talking about that. So absorption is going to be through the facilitate diffusion. Facilitate diffusion. Even though a little bit more, facilitate diffusion go from high concentration towards the low concentration. That is passive transportation. High to low concentration. Remember, we was talking towards the concentration gradient. Towards the concentration gradient. What does it mean? That they go from high to low concentration. All right? And that is through a facilitate diffusion. So facilitate diffusion absorption will be the fatty acids, the monomer of the fat, the monosaccharides, the glucose, galactose, the fructose. Those are monosaccharides. Parenthesis, disaccharides cannot be absorbed because are too big. Di means two molecules. So that is already too big to be absorbed. So they need to always to be in the monomer, in this case, the monosaccharides. And the proteins cannot be absorbed as proteins. They need to absorb in the components, in the actually in the form of amino acids. You have a puzzle, and the puzzle is the whole protein. Cut it in pieces. Each piece is the amino acid. That is how they are going to be absorbed. There is no other way. Okay, the absorption. So what is absorption? Is the transition or the transportation from one place, from the lumen. You know what is lumen, right? Lumen? What is lumen? Lumen? What is lumen, please?
Base of a hollow organ.
Excellent. Everybody has equal opportunities to participate. I can hear only 2-3 students. We have 24 students. Where are all of you? Okay, so I'm trying to do my best. So what about if I do? All right, so GI tract function. Food undergoes with the following type of processing body: digestion, absorption, elimination. Organs, digestive tract. Accessory organs. So do you want me to do that? No, right? So I want your participation for that. Okay, so we have the absorption, the elimination. Elimination will be the fecal material. Tell me one thing. If you eat a banana right now, or you have a meal, how soon you go to the bathroom? Probably in the next hour, probably in the next 2 hours. Yes or no? Right?
Yes.
Yeah. So tell me, if you eat a banana, that banana is going out of your body in 1 or 2 hours? Yes or no?
No.
No. Right? The banana is going out, the remainder of the banana is going to go out in about 1 to 2 days after you eat. So what is the food that we are doing after we eat, after meals, is what you ate 1 or 2 days before that day. Is that clear or no?
Yes.
Yes.
Okay. So, but why is important to know that? See, the next level. Why is important to know that? Why is important to know that? So if you know that the food is going to go out of your body, the remnants are going to be in 1 to 2 days, what does it mean? That means that the body require and need at least 1 to 2 days to absorb efficiently all the nutrients. See how the perspective is changing now? Just to know that fact. Okay? We okay with that? So need 1 to 2 days in order to be absorbed efficiently all the nutrients. Is that clear or no?
Yes.
Yes.
So that's why the GI tract from your mouth to the anus, if you put all the line like the tongue, the esophagus, the stomach, the small intestine, large intestine, like a line, is going to measure 20 feet long. 20 feet long. Can you imagine? 20 feet long, 6 meters about and plus. And why is too long? Why? Because they need time to absorb the nutrients. That is the reason. Okay?
Yes.
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 Okay, so tell me one thing. And that is the same example I gave you in the past. I'm going to repeat it again. So tell me, when you go to the restaurant, what you like restaurant, right? You like restaurant? No? Very good. Well, now is some of them is open. But okay. So restaurant. So you go to restaurant, what is the first thing you going to ask? The New York steak or your soup?
Soup.
Soup, right? So why you ask first the soup? Why you don't take the soup after the New York steak? Why? Why you doing that? Because
To prepare
everybody's
your
doing the
body.
same? Huh?
No,
Because
to
looks
prepare
good?
your body for the
Because
steak. To prepare your body for the steak.
excellent, very good. All right. You take the soup first because the soup is easier to digest. It's easier to digest. What does it mean? That means that you start eating, your body start to produce gastric acid. Start is the beginning of the production of more gastric acid. So that means with the soup that is easy to digest, you initiate the secretion of gastric acid. That means that you are preparing your stomach with a good pool of gastric acid to receive the heavy meal that is the steak, New York steak. Make sense or no?
Yes.
Okay. Soup, salad are easy to digest. Soup, salad. So that's why we have that at the beginning. And then you say, what is coming? My New York steak, right? Or your rib eye, prime or Angus or whatever, grass fed. Oh, very nice, right? Okay. All right. So the GI function will be the digestion, absorption, and elimination. Digestion, absorption, and elimination. Question for the exam. Okay. Digestive tract, we have the oropharynx, esophagus, stomach, small and large intestine. That is the digestive tract. And you know that it's being divided in upper and lower. The upper go down to the duodenum, including the duodenum, up to the duodenum, that is the upper GI tract, including the duodenum. So what is the upper GI tract? The oropharynx, the esophagus, the stomach, and the duodenum. Then the lower is after the duodenum, the jejunum, the ileum, and the rectum, and the colon sigmoid, etc. Okay? Melena, upper GI bleeding. What else? Hematochezia, lower GI bleeding. And hemorrhoids, or distal portion, or rectal bleeding, distal, very close to the anus, are going to be very reddish. Okay, we got it? Accessory organs, we have the salivary gland, the teeth, and remember, I remark here, salivary glands secrete water and amylase, ASE, enzyme, amylase. It's going to be what? It's going to be digesting the carbohydrates. All right, so here we have the salivary glands. So please pay attention to this. We have parotid glands. Can you see the parotid gland? We have the sublingual, and we have the submandibular. We have, this is on the right side. On the left side, we have another three. So we have three pairs. Parotid gland, parotid gland, parotid gland. Look at this. Where is the parotid gland? Look at that. Can you touch here on the front of your ear, here, below here? Can you touch it? Homework. That is parotid gland. There is a parotid gland. That is the parotid gland. That is coming salivary gland into is going to drain by a tube. It's an exocrine. It's going to drain by a tube saliva. The sublingual, under the tongue. See, when you see something that you are hungry, you're salivating, even drooling for food, right? That you are producing this saliva, sublingual. It's even jumping out of your mouth sometimes, right? The submandibular. So we have two submandibular, two sublinguals, and we have two parotid glands. You okay with that?
Yes, so two
Yes.
of each, correct?
Yeah, two of each. And the largest one, question for the exam, is the parotid gland. Parotid gland. Please don't get confused with the parathyroid gland. That is not parathyroid gland. Parathyroid gland is different chapter. Okay? This is the parotid gland. You okay?
Yes.
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 Okay. You know what? In the last 2 months, I was reading that was still having some new discoveries in anatomy physiology. New discoveries. There is another salivary gland that is posterior in the middle, a pair, but is central. Those are the tubular salivary glands. It's not in the textbooks yet. Probably it's going to appear in the next 5 years, but not now because they was just a recent discovery, and forget about NCLEX, okay? At this moment, for NCLEX, anatomy physiology, we have the parotid, sublingual, and the submandibular. We okay with that?
Yes.
Yes.
Okay. The wall of the small of the intestine. So I'm not going to ask the names of the mucosa, submucosa, smooth, and serous membrane. So I'm going to make remarks that you must know very well. The wall of the digestive tract, the wall, if you take the wall, the thicker, how thick is the wall of the esophagus, the stomach, the small intestine, large intestine, all they have the same thickening. The same thickening. They measure about 3 millimeters, 3 to 5 millimeters, 3 to 5 millimeters thicker. That is how thick is the wall. 3 millimeters, very tiny, right? So why is important to know that? Tell me, please, if you have an ulcer in the stomach, 3 millimeters is what the average should be. If you have a bleeding, because the gastric acid is making a hole in your stomach, 3 millimeters is very narrow, so you can have a perforation of the stomach, a perforation of the duodenum, and that is dangerous. They can lead you into sepsis, because all the nutrients, all the food are going to get into the abdominal cavity, and basically just sepsis and death. Okay, so
Dr. G, is perforation like a large breaking or a small?
Okay, perforation could be any size. Also, okay. I will tell you. Now you're asking that. Very good. So the ulcers, when the ulcers are more than 1 centimeter, 1 centimeter or more, that means 10 millimeters long, not deep, long, they need to resect that portion of the stomach. Why? Because it's imminent. It's at any time it's going to lead into perforation. They go deeper, and they produce gas, food coming out into the abdominal cavity. So 10 millimeters is the size of ulcers that we decide to do a resection of that area. Okay? All right?
Thank you. That's helpful.
Excellent. So then we have the 4 layers. The mucus, you know, the mucus of the stomach, mucus of the esophagus, etc. Then we have the submucus that is below the or under the mucus. We have the smooth muscle. This is huge, please. A smooth muscle. Remember, a smooth muscle or involuntary muscle. This smooth muscle is going to be contracting the smooth muscle. Giant cat, remember? The acetylcholine, please, acetylcholine means cholinergic effect, yes or no? Cholinergic, right?
Yes.
Cholinergic, right?
Yes.
Yes.
Okay.
Yes.
The smooth muscle are going to lead into peristalsis. Write it down that here. Peristalsis, 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 peristalsis. Peristalsis means this is a tube contracting here, but in front is relaxing. So the foot is going to go from more pressure to less pressure. Then it's going to, behind that is going to increase the pressure. They are going to put pressure here, but relax the pressure in front. So all this weird explanation is to let you know that all the content of the GI system, GI tract, is going to be always forward, never backwards. That is peristalsis. Peristalsis. So the peristalsis, and please remember this: when you want to go to poo, tell me, when you want to go poo, you want to go poo when you feel the sensation that you need to go to poo, yes or no?
Yes.
What is making you have this sensation to go to poo? The sensation is going, sorry?
A contraction?
The peristalsis. Let's change that into peristalsis, okay? Peristalsis. Very good, very good. Peristalsis, right? So what is doing peristalsis? Peristalsis is moving forward the fecal material, right? Moving forward, moving forward, moving forward. So what happened with the rectum? The rectum, please, the rectum. The rectum, what is going to do is to start to accumulate the fecal material. Accumulate the fecal material. The rectum start to accumulate. And the rectum is like a rubber band. The rectum is like a rubber band. Rubber band means that if you pull the rubber band more, what happened? The rubber band is pulling you back harder, yes or no?
Yes.
The more you distend the rectum, the more contraction is going to occur, like a rubber band. You pull it, the rubber band, boom, is trying to make you back with more strength, right? Yes or no, right? More force. So that is exactly what happened with the rectum. The rectum starts to accumulate fecal material, and there's distending the rectum, and the rectum by reflex are trying to contract. And that is the moment that you have the sensation to go to poo. Is that clear?
Yes.
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 Okay. So tell me one thing. If I have too much peristalsis, what is going to happen?
Diarrhea?
Diarrhea.
Diarrhea. Why is happening diarrhea? Why do we have water in the diarrhea? Or we don't have water?
We do have water.
Yeah. What is
Maybe
the
because
function?
we're not able to like break down what's in the stomach, or the
Okay.
and so then more water comes out instead of like food processed. I don't know.
Oh, okay. All right. Let's. Okay. Perfect. That's good. That's right. Beautiful. Okay. So I'll tell you, what is the function of the colon? Colon. Besides the flora, don't tell me the flora. Flora we know already. So what is the function of the colon?
Absorption of water.
Absorb water. Absorb water. Absorb water. What is the function of the small intestine?
Absorption of nutrients.
Absorption of nutrients. So why the colon is going to be absorbing just water? Why? It's so simple. Huh? Why is the colon absorb just water? Why the colon absorb water? Because all the nutrients are already being absorbed by the small intestine. Simple or not?
Yeah, I thought that was a trick question.
Why you didn't say it? Yeah, you may tell it. Okay. All right. So that's why. So now, if you have peristalsis, you know, I told you, tell me, when you have diarrhea, when you eat something, in 2-3 hours, the food is out or no?
No.
That's that you eat, right? Do you notice that or no? Everyone has diarrhea. Come on, right? Hello?
Mm-hmm.
Yes.
So when you have diarrhea, when basically you eat, and basically in few hours, what you ate is appears on the toilet, or no?
Yes.
Right? So why? Because the peristalsis is going to accelerate the transmission or the transportation of the fecal material. And what does it mean? That you don't have enough time to absorb the nutrients, including the water. So you have too much peristalsis, you're not giving enough time to the GI tract to absorb the water and the nutrients. So the water is going to be lost. And that's why you have diarrhea. You okay with that?
Yes.
Everybody got that, please?
Yes.
Okay,
Yeah.
perfect. Yes. So, and what is the neurotransmitter who produces the peristalsis? Which neurotransmitter is there?
Endorphins?
Huh? What is the neurotransmitter that causes the contraction of the smooth muscle peristalsis and
ACH.
the ACH? I heard, I didn't hear, so sorry. I now understand you were saying ACH previous. Excellent. ACH, the acetylcholine, cholinergic agent, correct? You okay with that? Are you ready for the question? Okay. So if I have diarrhea and I have too much peristalsis, what medication or what substance are going to take in order to stop the peristalsis or to decrease the peristalsis? If I have a cholinergic, that means cholinergic effect with acetylcholine, and remember, acetylcholine, everything wet. Yes or no?
Yes.
Yes.
Everything wet. Pee, poo. The same thing happened with the urinary bladder, with the saliva. You have acetylcholine, you're going to pee, poo, salivation. Everything wet. Now, if I have too much peristalsis, what about if I give anticholinergic? Make sense or no?
Yes, so it stops
Yes.
the effect.
Exactly, very well. So that's why you need to know the smooth muscle peristalsis. How we initiate the peristalsis. Do you notice that basically when you're not eating, you don't have basically go to the bathroom? That is depends. Everybody's different. But when somebody eat after 2, 3, half an hour, 1 hour, you start to go to the bathroom. Why? Because the peristalsis are going to increase during after meals. Why is that? Listen, you have a blanket, you have a blanket, you have a blanket, you have a blanket, and you're going to shake the blanket. Homework. Go homework, go to your bedroom and take your blanket and shake it out. Shake it. Okay? So what they're doing? Okay, very good. You're cleaning. Right? No, that is not the reason I'm asking you that. Because you're going to be the acetylcholine, and the blanket is going to be the intestine. So when you actually shake the blanket, you are sending the blanket is going to have these waves, yes or no, that are going to go forward, right? And
Yes.
that is the peristalsis. When you, for example, listen, you produce 1 liter of saliva every day, 1 liter, so you can fill it up 1 bottle of wine of your saliva every day, but you don't know, you swallow it, and this swallowing is going to be probably 1 every 2 minutes, 1 every 3 minutes. So, and every time you swallow, it's like you are shaking the blanket. Swallow, blanket shaking. So that is going to initiate the peristalsis. So in between meals, you are swallowing saliva only every 2, 3 minutes, and that is going to stimulate the peristalsis. But when you're eating after meals, you are swallowing and swallowing and swallowing and swallowing, shaking and shaking and shaking and shaking the blanket. So that is the moment that mostly the propulsion of the fecal material go to the feces. So when you finish your meal, you are in half an hour, 1 hour, or 2 hours, you have the sensation to go to the bathroom. You okay with that?
Yes.
Yes.
See? It's a favorite topic, right? Favorite, right? Yes or no? You like it? You like it? No?
Yeah,
Yeah.
it's good.
Dr. G, can we get a break?
Who is this? Shirley?
Yes.
Shirley. Very good, Shirley. Thank you for that. Very good. So what time is it, Shirley, please?
It's 11:03.
11:03. So let's have a lunch break right now, okay? Because this is a long class. I hope you understand that.
Okay.
Okay?
Okay.
So I
Okay,
will see
thank
you
you.
at 11:35. Everybody agree with that?
Yes.
Yes,
Yeah.
thank you.
Thank you, Dr. G.
Okay. We can be without break, huh? No, I'm not kidding. No. All right. So I will see you at 11:35. Thank you.
Thank you, Doc.
Perfect. Thank you so much. Thank you.
Sure, dear. Any questions so far?
No, so far everything's
No.
pretty clear and concise. Thank you so much.
Excellent. So I will see you 11:35. Bye bye.
Bye.
Very good, rinsing.
Vámonos.
See you smiling. That is a reward for me. Thank you.
Thank you.
Thank you, Miss. All right. See you then.
I can show you the world. Shining, shimmering, splendid.
Hello? I can show you the world.
I need a new song, Tom.
Shining, shimmering. Beauty and the Beast. Please fasten your seatbelt.
Hello. Okay, let's start.
Hello.
Let's continue. All right, so your cameras, please, everybody. Everyone. All right. Let's start. Let's start, not or begin. What is this? Okay. All right. So for this slide review, what is important? We have 4 layers. Then we have here the smooth muscle that is very important. One thing that I want to let you know is that in the mucosa we have a plexus. In the immersed between the mucosa and the submucosa, we have a nervus plexus. Nervus plexus. Plexus means it's a group of neurons. Group neurons. This plexus group of neurons are the ones who are going to be linking the smooth muscle. That is where these plexus are going to release the acetylcholine. You okay with that? Don't forget that. Plexus. Plexus is a group of neurons. Okay? So plexus are going to be distributed like this. This is the wall. Plexus are all over the smooth muscle. In addition to that, we have the Peyer's patches. Those Peyer patches are the lymphatic nodes that are located inside the wall of the intestine. You okay with that? Lymphatic nodes.
Yes.
We have the plexus. All right. So you will see in MedSearch why I'm talking about that, because there is people who born without this plexus, and they are going to decrease the peristalsis in those areas, and that produce the Hirschsprung disease. So that's MedSearch 1. But what my goal here is just to let you know that you need to be aware there is nerves that are going to be linked with a smooth muscle called the nervous plexus of the intestinal tract. Okay. All right, so just remember smooth muscle, acetylcholine, peristalsis. How initiate the peristalsis? Peristalsis is going to be stimulated by the swallowing. The more swallowing often you do, the more peristalsis you obtain. So that is going to fill up the rectum because the peristalsis is moving forward all the fecal material. Distending the rectum produce that sensation to go to defecate. Okay, we got it? Okay.
Yes.
So now we have this is basically the small intestine. The small intestine. The small intestine are going to have this villi. Do you eat the small intestine?
Yes.
It's
Yes.
like a towel, right? Inside is like a towel, right? So up and downs, up and downs, up and downs, correct?
Isaw.
So this up and downs is going to be this, the villi. So we have multiple villi. And this villi, on the top, we have the microvilli, the microvilli. All these small up and downs, up and downs, that is actually the villi of the small intestine. That is when you eat the intestine, you touch the intestine, it's like a towel, right? Up and down. And what is the purpose of that? The purpose of that is this: the intestine is no longer going, the lining of the intestine. Listen, the lining of the intestine is not going to be like this. The lining of the intestine will be like this. Okay? So what is the difference having this or this? This is going to increase the area of absorption. Make sense or no?
Yes.
That's why. So if you have, for example, all these villi extended like in a carpet, it's actually you will see the tennis court, the respiratory tract, they have that area for gas exchange. Alveolus, right? Okay. And the same area or similar area will be all the area of the intestine. If you spread out all the lining of the intestine in two-dimensional, so you will see that the area of absorption will be as the tennis court area. See, that is the absorption area that we have really in our GI tract. Remember the lymphatic nodes? Lymphatic nodes. Remember that we have the nerves that are going to be attached to a parasympathetic nervous system that is the acetylcholine, involuntary system. Okay, so everything is being coming together. Okay, we got it?
Yes.
Yes.
All right, so talking about the peritoneum. The peritoneum, imagine you are in the abdomen. Your room is the abdomen. In each device that you have in your room is an organ. Organ will be the small intestine, organ the large intestine, will be the liver, will be the stomach, will be the spleen. So some devices, all the objects are going to be one organ in your room. So what happened with the peritoneum? Can you see the curtains? The curtains in your room. You curtains, that curtain represent the peritoneum. Imagine that curtain is all over covering the walls of the room. In addition to that, imagine that peritoneum, that curtain is going to cover your desk, is going to cover your TV, is going to cover your computer, is going to cover your bed, is going to cover all the objects are going to be covered by peritoneum. So the intestine, the liver, the spleen are going to cover by peritoneum. Okay, we got it? So that is the peritoneum. Peritoneum is a membrane that is a double layer membrane that who has the parietal and the visceral with fluid in between to decrease the friction. Friction of what? The movement of the intestine, peristalsis. We okay with that?
Yes.
Now, look at this. Very important. Clinical nursing consideration here. You will see the application of that. I want homework. Stand up, take the blanket of your bed, take one corner, another person, another corner. So 4 people on the corners of the blanket. Stretch out the blanket. Stretch out the blanket. The blanket, then close your eyes and throw a coin on the blanket and try to know where the coin is hitting the blanket. Very difficult, yes or no?
Yes.
Right? So you know
Yes.
that the blanket is shaking. You can tell that something is dropped on the blanket, but you don't know where exactly. Yes or no?
Yes.
Listen, the application of this. The peritoneum is very rich, innervated. You know, innervation is something that I ask you to remember. Innervation means the group of nerves that are going to attach to the organ. All right, so innervation. So and the peritoneum have a high innervation of nerves. Nerves are all over the peritoneum. So when you have some pain somewhere else, it's very difficult to find out where is the pain. So it's not very well localized. It's a diffuse pain. Why? Because when you are basically having the blanket stretched out and put a coin on the top, the coin is the irritation, is the problem, is the infection, inflammation. And you can tell that all the blanket is shaky. So you have a diffuse pain without, very difficult to find out where is the pain. We okay with that?
Yes. Yes.
Yes.
So when you have abdominal pain, you need to basically you need to remember that is a diffuse pain. The pain can come from any place. So it's not very well identified. But you will say, but I have problem in the gallbladder. Yes, I have problem in the urinary bladder. Yes, I know that. I know exactly where is the place. Yes, because there is different type of pain. One pain is the visceral pain. Visceral means organ. This visceral pain is the pain that is covered by are going to stimulate the peritoneum and produce a diffuse pain. But it's going to be somatic or localized when it's already involved the pain, involving the wall of the abdomen. So that is more severe. So that means that the problem of the abdominal area is getting worse. It's very localized. That because they start to involve the abdominal wall. So we have two types of pain: the visceral and the somatic. Visceral and somatic. Visceral means organ, pain around the organ, and the somatic is when it's very low, very well localized. So the visceral pain can develop or can turn into somatic and more focalized when the pain or the problem is getting worse. You okay with that?
Yes.
So that is something that you need to keep in consideration when you are doing the palpation and the physical exam of the abdominal area. The other type of pain that I want to mention here is the neuropathic pain. Neuropathic pain. Neuropathic pain. That is different. Neuropathic pain is a pain that when you hit your arm, you have like a very electricity sensation. That is neuropathic pain. That is different from somatic and visceral. So you already know that we have three types of pain: the visceral, somatic, and then neuropathic. Visceral, somatic, neuropathic. Visceral, somatic, neuropathic. Neuropathic is tingling, electricity, like electrical sensation. Somatic, very well localized. Somatic localized. Visceral, very diffuse, difficult uh, to identify the location. We okay with that?
Yes.
Okay, let's talk about the stomach. Let's here. Okay, so so I didn't skip anything. That is basically what we are going to talk about the stomach in a few moments. All right, so that is cross section. I'm not going to go on that. All right, so organs of the digestive tract: alimentary tract or gastrointestinal tract, mouth, pharynx, esophagus, stomach, small intestine, and the large intestine. Okay, so remember the small intestine start where? The small intestine starts on that duodenum. Duodenum. The small intestine is three components: duodenum, jejunum, and ileum. Those are the three components of the small intestine. A small intestine. Okay, the mouth. So what is the functions of the mouth? The mouth will be the ingestion, right? When you put a food in your mouth, that is called bolus. So So let's start to understand each other. Bolus. Bolus. You okay with that? Bolus. Mastication is going to be a process of mechanical digestion. So we have digestion. I'm going to put digestion here. Digestion is going to be mechanical and are going to be chemical. Chemical will be the gastric acid, the enzymes. Mechanical is your tongue, your teeth, and your mastication process. Mechanical. Digestion means breaking down in small components. So the mouth will be the mastication, the ingestion, mixing with the saliva, mixing with the saliva. Saliva is why we need to mix with the saliva, because we want the water and the amylase to be more in contact more often with the nutrients in order to be digested. So mixing is a very needed thing, because otherwise you will not have a good digestion. Deglutition is going to be the swallowing itself. I'm not going to go talk about the teeth. We have 32 teeth, right? Permanent teeth. So that's all what I'm going to talk about. The pharynx. The pharynx, we have the nasopharynx, oropharynx, and laryngopharynx. So we already know that from previous class. The esophagus. The esophagus is going to, this is important, esophagus is going to be measured about 12 inches, 15 inches long. And this esophagus is the transportation of the bolus. When you eat something, when you swallow, bolus, and they go to the stomach. In the stomach, when you have the gastric acid plus the bolus, is going to be called now chyme. So bolus, chyme. Bolus is passing from the mouth to the esophagus, and when they go to the stomach, it's called chyme. We okay with that?
Yes.
Okay, so now this is taking about 10 to 15 seconds. 10 to 15 seconds. That is the time that the bolus is going to be passing towards the, until they reach the stomach. 10 to 15 seconds. 10 to 15 seconds, okay? When you have, some people have cancers, they have some obstruction of the esophagus here. And this is going to narrow the lumen of the esophagus. So when you are going to have this test, you go test, I'm not going to talk about that, a test that are going to check how long it's going to take the food to get into the stomach with imaging, with x-rays. And they are going to tell that this transition is going to be half a minute, 40 minutes. So that means that could be an obstruction here in the esophagus that can make you think that could be a spasm or could be a cancer of the esophagus. All right, so let's talk about the stomach. The stomach is very important, so please. The stomach, we have the fundus. All this is the body, and this is the antrum. This portion is going to be the pylorus. So we have fundus 1, body 2, antrum, and 3 pyloric area. 1, 2, 3, 4. 1, 2, 3. How many components we have? 4. Fundus is on the top. Then these fundus are going to be then the largest portion of the stomach is going to be the body, then is going to be the antrum, and then the pyloric area. We okay with that? Hello?
Yes.
Okay.
Yes.
Please. Okay. So now look at this. This is the diaphragm. The diaphragm is here. The diaphragm is going to be literally perforated. It's going to be passing that esophagus. This is the esophagus. Okay. This esophagus are going to have an sphincter. Okay, sphincter. This sphincter are going to put the sphincter. A sphincter is like this. So let's make a cut here. And what you're going to see in this esophagus like this, a cross-sectional. So you will see that this is the lumen, here the lumen, and the sphincter are muscle, like a ring muscle. This ring muscle is going to open when the bolus is passing to the chyme, and it's going to close when the bolus or when the chyme is already in the stomach. All right, so that is this is a valve or a sphincter, valve or a sphincter, and that is going to allow the passage of the food only in one direction. In one direction. How is this sphincter called? Very simple. It's the gastroesophageal. Esophageal means esophagus. Sphincter. Very simple. The stomach and the esophagus. What is the sphincter called? Gastro from the stomach, esophageal sphincter. You okay with that?
Yes.
Okay, perfect. So now let's continue. Here we have another sphincter. So the sphincter will be in the transition of organs. For example, esophagus to stomach, there is a sphincter. From the stomach to the duodenum is the beginning of the small intestine. That there is another sphincter. This sphincter, very simple, is going to be called the pyloric sphincter. Pyloric sphincter. Pyloric sphincter. Or you can call the gastroduodenal sphincter, but most commonly, 90% of the cases we call pyloric sphincter. Okay, this pyloric sphincter have the same function of the previous one. They are going to allow the transition or the passage of the chyme into the duodenum only in one direction, to the stomach, to the duodenum. You okay with that?
Yes.
Okay. In addition to that, the stomach is going to have the lining of the stomach. Remember, 3 to 5 millimeters thickness of the wall. But here we have gastric acid in the stomach. Gastric acid. We have gastric acid in the stomach. Gastric acid. How the gastric acid is not going to perforate or make a hole on the stomach. Why? Because we have, as you said already, mucus. We have mucus here. It's a barrier. It's a very thick mucus. It's a very thick mucus. This mucus is going to protect the stomach. It's going to protect the stomach. So from the gastric acid. You okay with that? You follow me? Yes?
Yes.
Yes.
Okay. All right. So then, but one thing I want to tell you. Somebody has gastritis. Everybody has gastritis once in a while, right? And the gastritis produce what we call the heartburn. Yes or no?
Yes.
The heartburn, what is the heartburn? When you have too much gastric acid here, the sphincter, the gastroesophageal sphincter is going to relax. And actually, especially when you lay down flat, the gastric acid go to the esophagus. And that can produce this sensation of burning. That actually is called, please, heartburn. You are in the medical school. You're going to call that pyrosis. Pyrosis. That is the real name of the heartburn. Heartburn, you can talk to the patient. Oh, heartburn, yes. But when you're talking to another nurse or a doctor, you're going to say pyrosis. Okay, we okay with that?
Yes.
One more thing that is very important. The esophagus is different from the stomach. The esophagus, what it's doing is to transport the bolus into the stomach. So that means that the esophagus do not have the mucus protection that the stomach is having, because the esophagus is not the stomach. The stomach have a mucus protecting from the gastric acid, but the esophagus is not going to have that. So that's why with any gastric acid reflux coming from the stomach is going to damage the esophagus, because the esophagus do not have that mucus. You okay with that?
Yes.
Yes.
Okay, perfect. So all this, by the way, I want to just mention one more thing before I forgot, is this sphincter is called the gastroesophageal sphincter, right? We talk about that, right?
Yeah.
Or called the cardiac sphincter. Why is called cardiac? Oh my God, it's the heart. No, it's not the heart. The heart is here. because of the proximity is close by the gastroesophageal sphincter is called the cardiac sphincter or cardiac area in the cardiac area or cardiac sphincter, just cardiac sphincter. So that's why. It's because it's close to the heart. It's not because it's something to do directly to the heart. You okay with that?
Yes.
Okay, perfect. Now, I prepare all this for this reason. Are you ready? Perfect. Okay, so now, this is very important, so please pay attention very much. We already know that the bolus is going to take about 10 to 15 seconds to get into the stomach. And now that is going to be called chyme. Correct? Yes or no?
Yes.
Yes. Okay, perfect. Listen, write it down 100 times homework. The chyme, how long is going to be in the stomach? How long is going to be in the stomach? The chyme is going to stay in the stomach between 30 minutes up to 1 hour. 2 hours, sorry. 1 hour. 2 hours. 2 hours. You okay? That is important. Stay is going to so 30. So we have food here. Chime. At 30 minutes, the chyme start to pass. 30 minutes start to pass. And 2 hours, that means that the stomach is already empty. We got it?
Yes.
Okay. 30 minutes, you take something, and in 30 minutes, it start to be absorbed in that way. Because the function of the stomach, we are talking about the stomach, is the digestion. Digestion. The digestion is going to be here mechanical. Why mechanical? Because the stomach, when you have something in your stomach, the stomach starts to have peristalsis. Peristalsis is not only the large intestine. It's not just the small intestine. It's not just the stomach. It's not just the esophagus. Peristalsis is going to start from the esophagus, then continue to the stomach, continue to the small, large intestine, to the rectum. So peristalsis is not just one area. So peristalsis is going to affect the stomach too. So the peristalsis, what it's doing is to do mixing all the chyme with the gastric acid. That is mechanical digestion because a mechanical force. And we have the chemical digestion because the stomach is going to contain the gastric acid. Gastric acid is HCl. That is gastric acid. You need to know that. Gastric acid. And the pH of the gastric acid is 2. Very important, 2. So whatever I say, remark, please, okay? We okay with that?
Yes.
Now, as usual, now we are going to know why we need to know this. Why is your nursing consideration now? Look at this. Very important. You are going to go to the next level right now. Just remember the stomach start to passing the chyme into the duodenum in half an hour. So the transportation of the chyme is going to start at 30 minutes after you eat. And then you're going to have 2 hours where the stomach is completely empty. There is no more food there. You okay with that?
Yes.
Okay. So tell me, I'm going to tell you this. The application about this. You have pain. You have pain. Whatever, any pain. And you take, let's take Tylenol. You take Tylenol. How long you need to wait until the medication start to be effective?
About an hour.
At what time? So when the medication start to be effective, is because it's being absorbed already. Yes or no?
Yes.
Yes.
Right. So at what time you start to have feeling the effects of the painkiller?
30 minutes.
30 minutes. Very well. 30 minutes. So just apply at home. You have pain, you have something, whatever situation, you take a medication for hypertension or whatever, diabetes, whatever you're doing. So taking any pill, the pill is going to be dissolved with the gastric acid in the stomach. And they start to initiate the passage into the duodenum, where the duodenum starts the absorption. And the effect begin at half an hour. That is half an hour. So when you are having another consideration, when you have a patient in the hospital, in the bed, oh, I have pain. So, okay, so let's check if you have PRN, right? Just as needed. PRN. So, yes, PRN. So I'm going to give you Tylenol. You get a pain killer. And then you need to assess if the medication is making effect or not after half an hour. You're not going to come after 15 minutes, after 20 minutes. Minimum, you need to check the patient in half an hour. Make sense or no?
Yes.
Make sense or no? Everybody got that?
Yes.
Yes, Doc.
Yes.
Okay, perfect. So that is why. Now, tell me one thing. When you have a wound, let's make a wound. You have a wound in your arm, okay? You have a wound in your arm, okay? We got it?
Yes.
Yes.
Okay. Now, this wound, you're looking, oh, it's healing, very nice, whatever, right? And somebody or yourself, you are doing this. What happened? Pain and bleeding, or no?
Yes.
Pain and bleeding. Okay. What about if I have an ulcer here? Ulcer. And what happens if I have an ulcer here? These ulcers are called the peptic ulcer disease. Do you know somebody with that? Peptic ulcer disease are ulcers in the stomach and or in that duodenum. That is called the PUD. You okay with that?
Yes.
Okay. So tell me one thing. If I going to eat and I have an ulcer, the food is going to pass through the ulcer. My arm and the food is my hand. Yes or no? And that is going to activate the ulcer. You okay with that?
Yes.
You can identify where is the ulcer. If you start to eat and the pain starts in less than half an hour, that means that the ulcer is in the stomach. But if the pain is going to start after half an hour, that is, and the ulcer is in the duodenum. Nice or not?
Yes.
Correct? Everybody got that, please?
Yes.
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 Okay, perfect. All right, so let's talk about the small intestine. The small intestine is going to be the duodenum. We have start with the duodenum, first part, the second part, the jejunum, and the third part is the ileum. All right, for this, I need to make you, this is very intense. So please, this is crucial, important. We are going to apply everything that we learned already. So here we have the pancreas. Oblique because the pancreas is like that, oblique. Okay, this is the pancreas. And the pancreas have the pancreatic use. Pancreas is a mixed organ, mixed gland. It's going to be exocrine and endocrine. The endocrine is going to be the insulin, glucagon, and somatostatin. Okay, so that is, we talk about that in endocrine. And exo is going to be the pancreatic use. Why exo? Because they have a duct. This duct, I'm going to make it a little exaggerate, It's going to measure about 2 millimeters to 3 millimeters. Okay, doesn't matter. Pancreatic duct. That is the pancreatic juice is going to have, this is the pancreatic duct. Pancreatic duct. This pancreatic duct is called, open eyes, open ears, the Wilson's duct. Wilson's duct. Because the duct is exocrine function. So this is like a big river. This is like a big river. The river is going to have confluent rivers. So there are going to be the glands, the glands, the glands, the gland, the ducts, the river, the contribute rivers. Those are the glands. And these glands are going to produce actually the pancreatic juice. What is the pancreatic juice? Pancreatic juice is going to be number 1, the amylase. Question for the exam. Number 2, question for the exam, the lipase. Number 3, the protease. Number 4, please be careful with this, bicarbonate. Bicarbonate. You need to know this, and I told you in the past, you need to know the formula and you need to know the name. Bicarbonate. Don't forget the minus here. This is going to be very alkaline. Very alkaline. And these are going to give the pancreatic juice a pH of 12. And you will see why it's important. pH 12. Very alkaline. So we have amylase that are going to digest carbohydrates. Lipase, lipids, right, is going to digest fat. Proteins are going to digest what? Proteins. We okay with that?
Yes.
Yes.
In addition, we have water. In addition, we have electrolytes. That is the whole cocktail of the pancreatic juice. Electrolytes. Okay? Okay, perfect. So now, this pancreatic duct is going to, I'm going to draw in different, I will say this, are going to, I don't like the color. Going to do, I don't know which one. This blue, okay. So we are going, this pancreatic duct is going, this pancreas is going to be in relation with the duodenum. With the duodenum. The duodenum is coming here. The duodenum. This is the duodenum. Duodenum. First, second, and third portion. We don't care. Duodenum. This is going to drain, the pancreatic juice are going to drain into the duodenum. You okay with that?
Yes.
pH 12. pH 12 in the duodenum. In addition to that, I'm going to draw the bile. This is the gallbladder. And the gallbladder is going to go into the here in this area. They're going to drain together. Oh God. Okay. Are going to drain together with a pancreatic duct. They're going to drain together. Yes. They're going to drain together. So here's coming the bile. Okay. The bile is produced by the liver and is stored in the gallbladder. The bile are going to be this. Listen, the bile is going to be composed by bilirubin. You know the story of the bilirubin, right? Yes? Spleen, 120
Yes.
days, hemoglobin, etc. Right? Plus, we have the cholesterol. Cholesterol, yes, we have cholesterol. The bartender is going to put bilirubin cholesterol. Plus, we are going to have the lecithin. Plus, that is amino acid. Then you have the bile acids. Bile acid. Bile acid is huge, so that's what I'm going to talk right now. The bile acid. The bile acid. That is what is making difficult to explain everything. And then we have, but let's try to make it easy, water plus electrolytes. Okay? So why do we need the bile? Yes, why do we need the bile, right? Why do we need the bile? Why do we need the bile? One of the functions, because it's time, we are going to talk about the bile acids. The bile acids. The bile acids. So Here are going, these bile acids is what we call the emulsifier. Question for the exam. Emulsifier, 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 emulsifier. What does it mean, emulsifier? Emulsifier of fat, okay, of the fat, of the fat. No emulsifier of the proteins, no the carbohydrates, emulsifier of the fat. Emulsifier of the fat. We okay with that?
Yes.
Okay. So what means the emulsifier? So we have the fat eating in your food, and the fat is going to be like this in your drops, right? Yes or no?
Yes.
Drops.
Yes.
Drops. So now it's coming the emulsifier here, and what is going to produce? These drops are going to be like this now. They are going to be droplets. Example, go to the kitchen, homework, wash your dishes, put some oil or some fat in the sink, and put some detergent. What happened with the fat? Right? Yes or no? Separate. Right? Or no?
Yes.
Hello? Okay. And that means emulsification. They are going to emulsify. They are going to emulsify. So they are going to make the fat from drops to droplets. So go to the sink, put detergent. Detergent is the emulsifier. It's like equivalent to, say, bile acid. I'm not saying your bile acid is a detergent. I'm just trying to compare. Okay? All right? So what is important about this emulsifier? Look at this. We have the lipase. When you have here, the bile is coming together with the pancreatic juice. The bile. This is the bile with the bile acids. So it's coming together into the duodenum. Look at that, duodenum. Okay, that is going to be the pancreatic juice, right? Pancreatic juice. The pH of the bile is about 6.5. It's a little bit acid, but it's not relevant at this moment. All right, so we have the pancreatic juice, pH 12, and the bile. That is going to bring the emulsifier. But what happened here? What is happening here, in addition, that here from the duodenum is coming what? Is coming the chyme, It's coming the chyme. The chyme. Is going to come the chyme. The chyme. And this chyme is going to have a gastric acid with pH 2, or no?
Yes.
Okay, perfect. So the chyme is going to come with the carbohydrates, with the proteins, with water, electrolytes, vitamins, minerals, and fat. Fat. Imagine when you eat too much fat. Too much fat. Okay, so let's see. So what happened? When the fat is coming with like this, like a drop. I'm going to make two only, just because the space. And then in combination with the bile, they are going to produce droplets. You okay with that?
Yes.
Now, at the same time, arrive the pancreatic juice. And what is important about this moment, about this specific topic, is the lipase. The lipase. The lipase, what it's doing is to digest, break down the fat. So if you have the lipase, I'm going to put it in red here, the lipase without the bile, they're going to find drops, big drops, and they are going to produce this effect. They are going to digest the drops. But now, when the bile is coming, the drops are going to be in droplets. So the lipase are going to have more surface area with the fat droplets rather than the fat drops. Yes or no? Make sense or no?
Yes.
All right. So let's imagine you are a classroom, and let's make a drop of fat. So everybody's fat. So I'm not saying okay. Everybody fat. So you're going to stand up. You're going to in the classroom, and everybody is going to hug each other. Hug each other. Hug each other. Okay, you have a big drop of fat. Then I'm at the lipase. I come in with my bucket of water, that is my bucket of lipase, the fluid, and I'm going to throw it to you. Okay? So who is going to get wet? The one who is going to get wet is only most likely the one who are in the peripheral area of the big drop. Yes or no?
Yes.
Yes.
Now, what happens if I ask you to separate each other? Separate each other. And then I do the same procedure. I'm going to spread out with my bucket with bile acid. Who is going to get wet with the bile acid? Mostly everyone. Yes or no?
Yes.
So that
Yes.
means that the lipase will be more effective after the emulsification. True or false?
True.
True.
True. That is why we need the bile. The bile acid. Bile acid. You will see in pharmacology, in MedSearch, bile acid. You will see that. So you need to know bile acid equal emulsifier. Drops to droplets. What? The fat. Why? Because that improves the action of the lipase coming from the pancreatic juice. You okay with that?
Yes.
Yes.
Okay. Third. Now, third, we have the pancreatic juice, and these amylase and lipase and the protease are enzymes, as you can tell, enzymes. Yes or no?
Yes.
All right. Let's go back to bioscience enzymes lecture. The enzyme lecture, you already know. The enzyme, what is an enzyme? Is a substance that is a protein. It's a protein. Enzyme is a protein that have the function to accelerate the chemical reactions. That is number one. You okay with that? Okay. Now, the activation of the enzymes, the activation of the enzyme means that the enzyme start to get in action is when the environment of that the environment where these enzymes will be located, when the environment is neutral, pH neutral pH. So that means that this enzyme will be working only they're not going to work. It's too acid environment. No, it's not going to work. It's not going to work. It's too much alkaline. It's not going to work. It's going to work only when the environment is neutral, pH close to 7. You okay with that?
Yes.
Now, so that means, and that is, you're going to understand pancreatitis later on, so that's what you need to know this. So the pH here on the pancreatic juice is 12. So that's why this enzyme, you will ask me, why this enzyme? Because, pancreas is a tissue, it's a cell. Cell contain carbohydrates, contain proteins, and contain lipids, right? Or no? Phospholipids, etc. So why these enzymes do not destroy your own pancreas? Why? Because these enzymes are going to work only in neutral environment, not in alkaline environment. So when they come out with pH 12, they're going to find the chyme with pH 2. It's like you have hot water and cold water. Put it together, what you have warm water. So you have acid versus alkaline, pH 2 acid, pH 12 alkaline. They mix and they are going to neutralize. And that is why is the moment where the enzymes, the amylase, lipase, protease are going to be activated, not before. If that is going to be activated before inside the pancreas, produce the pancreatitis. Basically, you're eating yourself, your pancreas. You okay with that?
Yes, Doc.
Yes. Yeah.
Okay. As a summary of all this, there's one more thing I need to tell you. As a summary of this, what's the summary? Oh, yeah. Okay. The summary will be that is the duodenum is where most of the chemical reactions for digestion occurs. Is that clear or no?
Yes.
Yeah.
So it's in the duodenum where you have they have dual activity. The duodenum. I told you that small intestine is absorption. Yeah, but I'm including duodenum, jejunum, and ileum. But the duodenum have the particularity that produce the absorption too, plus is where mostly of the chemical reactions are going to occur for digestion. You okay with that?
Yes.
Yeah.
Okay.
Yes.
Now, the last thing for this. You don't know how important it is. You will know. No, hopefully you know already. This is very important. I'm going to so many questions about this. All right, so now, what is I going to say? Oh, okay. So tell me one thing. How in the world the body knows when to release the bile? How in the world the pancreas knows when to release the pancreas? When in the world the chime is coming, and the bile knows that the chime is there and release the bile? How in the world the pancreas know when the chime is in the duodenum and the bile is in the duodenum that they need to secrete pancreatic juice? Good question, right? Okay. So what happened is that the chime, when they get into the duodenum, when the chime is getting into the duodenum, they are going to do like this, like rubber yourself in the wall, doing this. Can you rubber yourself in the wall, homework? Right? Do this. So, what is the wall? The wall of the duodenum. What is you? You are the chime. The chime is making some friction on the contact with the duodenum wall, and that stimulates the duodenum to produce an hormone. This hormone is called the cholecystokinin. This hormone, the cholecystokinin hormone, this hormone is going to be the CCK, by short, CCK. So when the chime is in the duodenum start to release the cholecystokinin. This cholecystokinin, they go to the blood stream, to the blood. And from the blood, they're going to go to the gallbladder. And they're going to go to the pancreas. And this cholecystokinin is, it's a message, hormone, it's a message that is going to tell, okay, gallbladder, the chime is here, let's secrete the bile. Okay, pancreas, so we need to secrete the pancreatic juice. That is the CCK. Who produces the CCK? The duodenum. When the chime is present in the duodenum. Period. We okay with that?
Yes.
Yes.
Okay. So now, the last thing. What time is it, please?
12:27.
Yeah. You know what? I cannot. How we can do because I don't want to rush. Can you give me until 1:30? Somebody? So everybody can do it?
Yeah.
Yeah.
Yeah, that's fine.
Can we do one
Yeah, no problem.
a 10-minute break when you're done with this part?
Okay, all right. Let's do that. Deal. Okay? All right. So what I'm going to say? What I'm going to say? Okay, so
So the gallbladder and the pancreas get the information from the hormone to produce their functions.
yeah.
And then you said period.
Oh, yeah, I forgot something. There you go. Thank you very much. Thank you so much. Here in the pancreas, they're going to release the pancreatic duct. I'm going to make it bigger here, okay? To make it bigger. So this is the pancreatic duct, and that is going to be the bile duct. The bile duct, this is the Wilson duct or pancreatic duct. This is the bile duct, where is coming the bile. And the bile duct then is going to literally perforate the duodenum. They're going to pass the duodenum. So this is the duodenum. The duodenum. Okay? I'm exaggerating a little bit here. So it's smaller, of course. How many? 2 millimeters. All right. So this is passing the wall of the duodenum. So here we have an sphincter. Here's an sphincter in this area. So here that is going to involve the bile duct and the pancreatic duct. This sphincter is called the Oddi sphincter. Oddi sphincter. Oddi sphincter. This Oddi sphincter sometimes is called a papilla of Bader, or papilla of Bader. So another time I can tell you the difference, but when you say Bader or Oddi, all right, Oddi, so Oddi is the sphincter. Papilla is when you see inside the duodenum, you see like a papilla that where is coming the Oddi sphincter is ending. So that is, and what is the purpose of this? Is to prevent the reflux. You okay with that?
Yes.
Okay. So now here we have the villi of the small intestine. The villi of this is the small intestine, and we have a lot of villi, right? Villi. So in this villi is this one. On the top of the villi, we have microvilli that is going to increase the absorption of the nutrients, correct? Okay. So now here we have, in this each villi, we have an artery. We are going to have, in each villi is going to be a vein. A vein. And in each villi, we are going to have the beginning of the lymphatic vessel. Lymphatic. So we have here 3. Can you see here? Artery, vein, and lymphatic. You okay with that?
Yes.
Yes.
Now, here we have the lumen. This is the lumen. The lumen, where all the food is here, the nutrients are here. So the nutrients are already small enough, and they are going to start to be absorbed by these cells. And these cells, then they are going to pass into the venous system. They are going to pass to the venous system. Here is coming oxygen, because all the cells, they need oxygen, right? And they are going to release the oxygen for the metabolic reactions, and they are going to release carbon dioxide. So that's why it's blue here. So that is the vein. But in the middle, we have the lymphatic vessels. These lymphatic vessels are going to absorb what?
Excess fluid.
Okay, what else? Fat. Remember the functions of the lymphatic system? Very good. Remember that?
Yes.
Remember, it's going to be fluid balance, excess of fluid, right? It's going to absorb what? The fats and some proteins. So all the fat basically are absorbed by the small intestine through the lymphatic vessels. That lymphatic is called the lacteal lymph, lacteal vessel. Question for the exam. Lacteal vessel. The lacteal vessel is lymphatic. Lacteal vessel is going to collect mostly of the fat that is in the lumen of the intestine. You okay with that? And you know that the lymphatics are going to drain into the what we call the thoracic duct in the left side, and the left lymphatic duct on the right side. They go to the venous system after that. Okay, that is how the fat reaching the. There's some fat absorbed directly to the veins, but the most of the fat absorbed by the lymphatic system. You okay with that?
Yes.
So here we have the veins. So this is, can you see the villi inside of the small intestine? This is the small intestine, the villi. And these villi are going to absorb by facilitate diffusion. The fats, proteins, carbohydrates are going to be absorbed by facilitate diffusion. These facilitate diffusion are going to be collected by these vessels that we see here. And these veins are going to come together, and they are going to create these vessels. The superior mesenteric vein, the inferior mesenteric vein. Basically, those two. And these are going to collect all the absorption of the proteins and carbohydrates, some fats, because the fat mostly is absorbed by the lymphatic. So this is venous system. And this superior mesenteric vein plus the splenic vein together, this coming from the spleen, they are going to form the portal vein. That is the portal vein. Portal vein. And the portal vein go to the liver. Portal vein do not have valves, no valves. So the blood flow can go back and forth, depends, right? So, but mostly the blood is going to go towards the liver, portal vein. You okay with that?
Yes.
Large intestine, we have the before that, just a moment. Okay, so yes, the large intestine is going to be the ascending colon. Ascending colon. Why is ascending colon? Because it's ascending. Transverse colon. Why is transverse colon? Because it's transverse. Descending colon. Why is called descending? Because it's descending. Then we have the colon sigmoids. Why is called colon sigmoid? Because the letter Greek alphabet sigmoid is actually sigma, is the similar as the shape of the pathway of the sigmoid colon, and then ends into the rectum. Now, the first portion of the ascending colon is called the cecum. This is the cecum. This extension is the appendix. The appendix have a lot of lymphatic nodes. You can remove the appendix without any basically changes. Okay, the appendix. We think that this is a remnant of our ancestors. Okay, and comparison with animals, who has a large appendix? Animals who are carnivorous. So basically, animals who eat a lot. It's a theory. They eat a lot of meat. They have this large appendix, and because we are not carnivorous only, we are mixing with plants, with other products, fruits, etc. They are going. We are omnivorous. That appendix is a theory, so we don't know exactly what is the function of the appendix. Okay, all right. So we okay with that?
Yeah.
Now, the one more thing here. We have the small intestine here. It's a small intestine is coming like this. Small intestine. This small intestine then are going to go to the ascending colon. So this is the transition between the small intestine, the ileum, part of the ileum, to the large intestine, the cecum. So we have another valve. This valve is going to allow only the transportation from the small intestine to the large intestine. And that is the ileum portion. This portion is the cecum. So this valve is called the ileocecal valve or sphincter. You okay with that?
Yes.
So we have many sphincters: cardiac sphincter or gastroesophageal sphincter. We have the pyloric sphincter. We have the Oddi sphincter. We have the what else? Pyloric sphincter, I said, and the ileocecal valve or ileocecal sphincter. You okay with that?
Yes.
Yes.
Okay. So from this, yeah, we already know the parotid glands, or 3 pairs of salivary glands. These parotid glands, I want you to go homework, go to your mirror, open this like this, and in the second premolar, you will see an opening here, an opening in your gums, very high. That is the drainage of the parotid gland. All right, parotid gland is the largest gland. Parotid gland, salivary gland contain the amylase, water, and electrolytes. Okay, summary. This is the papilla beta. So this is looking from inside. This is an endoscopy. This is the duodenum. And this is the end of the Oddi sphincter. So papilla is like a bulging area. The functions of the liver, we already talked about that. Just remember, the portal vein who is bringing blood to the liver is going to give blood supply from the hepatic artery. This is the celiac trunk, the first branch of the abdominal descending aorta, abdominal aorta. And this is going to give branches to the spleen, splenic artery. It's going to go branches for the stomach, the gastric artery, and the hepatic artery. This is the hepatic artery, and the hepatic artery is giving blood supply to the liver. In addition, the portal vein is going to give blood supply to the liver, even though they have low levels of oxygen. But can you see how big is the hepatic artery, the portal vein compared to the hepatic artery? So this is the diameter of the portal vein, and this is the diameter, very tiny, of the hepatic artery. If you compare the amount of oxygen that is given to the liver, the one who gives more oxygen by volume is actually the portal vein. The portal vein then is going to drain blood into the liver. Then what happened? The liver start to be collecting that blood through the hepatic veins. Hepatic veins. We have three hepatic veins. Three hepatic veins. The hepatic veins, right, left, and middle. Well, you don't care about just hepatic vein. And look at this. The hepatic veins, where they are going to drain. They drain into the IVC. Huge, important. When you're going to do heart failure, you need to know this anatomical concept. Okay, have this anatomical concept. Okay, we got it?
Yes.
All right, so here we have the pancreas, all the enzymes. We have what is the pancreatic juice, pH 12, and there are all the components. Remember, bicarbonate, you need to remember with the formula 2. All right, so the bile, we already talked about the cholecystokinin, causes gallbladder contraction. In addition to that, they are going to cause the release of pancreatic juice from the pancreas. We okay with that?
Yes.
The bile functions are going to be the emulsification of the fat, as we already mentioned. All right, so that is basically everything that I have for you. Now, all the disorder, I'm not going to go in that because you remember everything that I mentioned is going to, or what I teach is going to be in the exam. I don't ask questions that I'm not teaching. Okay, we got it?
Yes.
Yes.
All right, so let's have a 10 minutes break, very well deserved, and we are going to do our urinary system. Okay,
Thank you,
Thank you,
Dr.
Doc.
G.
thank you. Any question? Any question? Alejandra? Alejandra? Okay, no, Alejandra.
Yes,
Shirley.
Dr. G.
Oh, how is the class so far?
It's good. Thank you.
Shirley, how is the class so far? Shirley, no Shirley. Jessica.
It's good. Thank you, Dr. G.
Okay, dear. All right. So I will give you 12:52. Okay.
Okay, thank you.
Okay,
Thank
thank
you.
you.
Hello,
Hello.
we are on time. We can start.
Yes.
Yes.
Okay. All right. So please, I'm going to go directly to the point here. Urinary system. It's so important. And with the time, I'm going to add more stuff, but definitely, this is what you're going to need. Okay. So let's go to the anatomy of the kidney. Okay. And then I'm going to make a summary of the function of the kidney. So please pay attention to this. We have the kidney is two kidneys. Okay. The kidneys are going to measure about 12 centimeters long. And the kidneys are side by side of the column. Side by side of the column. It's like this portion of the kidney, this portion is like laying down over very close to the column. So it's very close to the middle portion of your body. Don't think that it's more lateral. No, it's side by side, parallel to the column. Is okay, we okay with that?
Yes.
Okay. So we have two organs. So you can live without one. So you can survive with one because the other one are going to compensate the one who is missing. All right. So now here we have the blood supply. Before I forgot, the blood supply is going to come from the aorta. So the aorta, you already know, we have the celiac trunk here, we have a superior mesenteric artery here, and here is going to raise the renal arteries, the renal arteries, the renal arteries. The renal arteries, they are going to enter into the kidney through the hilum of the kidney. The hilum of the kidney. Remember the hilum of the lung, the hilum of the liver, the hilum is the entry or exit of structures, right? In this case, the hilum is the entry of the artery, is the exit. This is the renal artery, is the exit of the renal vein, and this is the exit of the ureter. The ureter. Okay? The ureter is going to measure about 2 to 4 millimeters diameter, and it's very narrow. Look at this. And I'm going to make a cross section of the ureter. This is the ureter. The ureter is going to have this configuration. So this is the lining, this is the lumen. This is the lumen of the ureter, and this is formed by a smooth muscle. A smooth muscle. The ureter all the way are going to have the smooth muscle. These smooth muscles are going to be affected by the acetylcholine that produce the contraction and the relaxation. In addition to that, the ureter are going to have what we call the peristalsis. So peristalsis is not only for the intestines. It's going to be the peristalsis, peristalsis, peristalsis. Peristalsis is the wavy contraction, relaxation of the ureter, who is going to contribute to the flow of the urine. You okay with that?
Yes.
Okay. Now you start to think about how many times you go to pee every day. Okay, we will see that. All right. So now, once they are getting, all these structures, we are going to divide the kidney in two main regions, the renal cortex and the renal medulla. So where is the renal cortex? Please pay attention to this. Renal cortex is this. Including this in between. Renal cortex, renal cortex, renal cortex, renal cortex, renal cortex, including in between this, renal cortex, renal cortex, renal cortex. Is that clear? And we have another portion that is called the medulla. So you must know the division of the kidney. Renal cortex and medulla. Medulla is all this. All this is the medulla. Okay, medulla. And then we have this area, this other area here, this area, all this area that is called the pelvis of the kidney, kidney pelvis. Okay, we got it?
Yes.
Okay,
Yes.
perfect, perfect. It's considered, some people consider the pelvis, the renal pelvis, part of the renal medulla. All right, So now, what I want you to remember is this. So the renal artery that is coming from the aorta are going to get into the hilum, and the hilum and this renal artery is going to divide in 4 to 5 branches. 1, 2, 3, 4, and 5. That is not seen here. So these branches, as they go more distal, they are going to travel and dividing in branches, 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 and branches and branches. These branches, the ultimate goal is to reach the cortex. The cortex. If you see here, the vessels are very tiny. If you see here some kind of yellow stuff here around the arteries on these vessels, can you see that?
Yeah.
That is actually what we call the nephron. So all these vessels are going to reach a nephron. How many nephrons we have? We have 1 million nephrons, each kidney. And this nephron is a question for the exam. Nephron is the functional unit of the kidney. Functional unit of the kidney. Okay, let's make a close-up. I said close-up. Okay. All right. So if you see here, these are the vessels coming from the renal artery. These vessels are going to reach what we call the nephron. Where is the nephron? The nephron is this. This is the nephron, not this. This is no. This is the nephron. I'm going to go into detail now. So what happened? If you see here, all these vessels are going to be branching, and then they are going to find 1 million nephrons, all distributed in the kidney. 1 million nephrons. When each nephron is going to receive a branch of the renal arteries. They're going to be segmental, lobular, arcuate, and they're going to be the what we call the afferent arteriole. So if you see here, I'm going to show you a nephron here. I'm going to draw a nephron. All right, so this, we are going to draw a nephron. This is a nephron. I'm giving you a nephron. The renal artery with all the branches are going to come here in each of the 1 million nephrons. This is an arteriole. That is a terminal branch of the renal arteries, the renal arteriole. This arteriole is going to be called afferent. Afferent, I don't know, afferent. Afferent means that it's bringing blood towards the nephron, in this direction, blood. Now, these afferent are going to get into this area that is called the Bowman's capsule. Bowman's capsule. This Bowman capsule is going to be like a glass. So what happened with the afferent? The afferent is going to get into this Bowman's capsule, and they are going to be like tangled, like this. Not tangled. It's going to be like a spaghetti in your plate. This spaghetti is called the glomerulus. Plural, glomeruli. Then after all this situation, they are going to come in and circles, whatever. They are coming out. They're coming out. This is called the efferent arteriole. So it's arteriole, capillary, arteriole. Very important, very curious thing is this. You know the arteries ends into arteriole, then capillaries, and then venules, and then veins. Remember that? But this is one of the few parts on the body, the liver, the brain, and some other two. They are going to continue artery, arteriole, capillary, and then arteriole again. See? You okay with that? So
Yeah.
that is the arteriole afferent and the efferent. How to remember that? Who is first, A or E?
A.
A. A is the afferent bringing in blood into the nephron, and efferent is the one who's going away from the nephron. We okay with that?
Yes.
Okay. So now, this is the Bowman's capsule. Question for the exam. Bowman's capsule plus the glomerulus is called the renal corpuscle. All right, so when I say renal corpuscle, means Bowman's capsule plus the glomerulus. Okay, we got it?
Yes.
Okay,
Yes.
so now I want you to imagine this tube. This is a tube. This is a tube. This is a hollow cavity. Hollow. It's like a tunnel, like a funnel. So here is going to have the filtration. How is happening the filtration? The filtration are going to make a piece of this glomerulus like this. That is a capillary. That is equal to, say, the glomerulus. The capillary are going to have openings. Remember that?
Yes.
Are called pores. And actually what happened is the water coming here. Water is going to have proteins, amino acids, let's put it that way, carbohydrates, fats, minerals, hormones, what else? Vitamins. All this is coming through this afferent. And these openings that we have in the capillaries are going to drain. So if these openings are bigger enough for these elements, they are going to pass. Who are going to pass? Are going to pass water, are going to pass glucose, are going to pass amino acids, are going to pass fat, vitamins, etc. So they are going to filtrate. It's like you have a spaghetti in your drainer. Actually, the filtration is going to allow only what is smaller than the openings. They are going to pass. Yes or no?
Yes.
Okay. So now here is going to be in this portion that is called, the first portion of this is called the proximal convoluted tubule. Or PCT. That is PCT. So what is the function of this PCT? The function will be the reabsorption. So when I say reabsorption, means that first of all is being absorbed already by the intestine. The intestine, the absorption are going to be in the intestine. Absorption. They go to the bloodstream, they go to the kidney, it's going to be filtrated, and then it's going to be absorbed for the second time. So that's why it's called reabsorption. You okay with that?
Yes.
Okay. And what is going to be reabsorbed? They are going to be reabsorbed only those. They are going to reabsorb these monomers, the glucose, the water, amino acids, and fat. The proteins are big like this. This is a protein. I didn't say amino acid. I said a protein. What is a protein? It's a group of amino acids. So these proteins are too big to pass through the pores of the glomerulus. So what happened? There's not going to appear in the urine. So there is no proteins in urine. You okay with that?
Yes.
In addition, the red blood cell is big. The red blood cell is not able to pass because these openings are not going to be big enough. So there are no blood in urine. There is no blood in urine. When you have proteins in urine and blood in urine, that is abnormal. You okay with that? So basically, they are going to absorb all the water, the glucose, the amino acids. Glucose, water, and amino acids. And from this process, filtration, the reabsorption, 85% of the absorption is happening in the PCT, in the proximal convoluted tubule. Okay? Look at this loop. Then it's going to continue. The proximal convoluted tubule is from here to here. That is the proximal convoluted tubule, the PCT. Then is coming this loop. Can you see this loop? Remember that word for the exam or whatever is a hairpin shape. Hairpin shape. That is going to be called the Henle's loop. They are going to produce some reabsorption. Okay? Basically, 15% of the reabsorption will be in the Henle's loop. And that is what we are, you don't need to know that yet, but is where produce the concentration of the urine. So here we have the counter current, whatever. So just remember the Henle's loop as anatomy, please. Okay? Then it's coming the distal convoluted tubule. So if this is the proximal, this is the distal convoluted tubule. That is going to absorb about 10%. About 10%. All right, so this is approximately. So 15 is, so it's going to be 80%, sorry, here. It's going to be about 80%, 10 to 15%. This is going to be 5 to 10%, okay? So, but the majority, the concept is that the proximal convoluted tubule reabsorb mostly all the reabsorption is going to happen in the proximal convoluted tubule. You okay with that?
Yes.
Okay. So what is a nephron? Nephron is the Bowman's capsule, the glomerulus, the afferent, the efferent, the proximal convoluted tubule, the Henle's loop, and the distal convoluted tubule. Period. That's it, the nephron. That's it. That is the nephron. Nothing else. You okay with that?
Yes.
Now, this nephron then is going to continue with a tube here that is called the collecting duct. It's called the collecting duct. It's called the collecting duct. So this is the urine. And the collecting duct is not part of the nephron. You okay with that? Okay. So let's go now to the big picture here. Can you see here some kind of lines here? Can you see this?
Yes.
Okay. Okay, so now the nephron that is located in the cortex of the, basically on the cortex of the kidney, they are going to be, that is the nephron. But the collecting duct, that is the last portion that I draw as a black, this portion, this one here, right? These collecting duct are going to go through the medulla. These are the collecting ducts. This part of the medulla, can you see this structure? This structure is called the pyramid because basically it's the shape of a pyramid. So we have 6 to 10 pyramids for each kidney. So that is basically the formation. So the urine is coming, and then they are going to be collected by the kidney pelvis. This is the pelvis of the kidney, and they go to the ureter, and they are going to drain into the what? Into the urinary bladder. You okay with that?
Yes.
Okay, perfect.
Yes.
So let's keep moving. So now here we have the close-up or whatever. Okay, so now I'm going to talk about the physiology. Okay, physiology. Number one, what are the functions of the kidney? Physiology. What do I say? Physiology. Physiology. Number one is the filtration. You know, the filtration happens where? At what level? Which level is happening the filtration, please, please? On the glomerulus. Glomerulus. We okay with that? At what level happened the filtration, everybody?
Glomerulus.
Glomerulus.
The second function will be the reabsorption. The reabsorption are going to happen in the proximal convolute tubule, are going to be in the Helmholtz loop, and it's going to be in the distal convolute tubule. The third is going to be the excretion. Excretion, for example, of urea. So that is going to go through all the nephron and then go to the urine, excretion. So that is the function of the, so they're going to eliminate the, actually the urea. Number 4, the secretion. This is very important, very confusing. So please pay attention to that. Secretion will be the hydrogens and are going to be secreted the bicarbonate, between others. So what is this? This secretion, that means the kidney, is going to participate in the control of the pH. pH, pH, pH. So what does it mean? So what is the difference between excretion and secretion? Excretion is when you eliminate and say goodbye forever. I don't want to see you again. If I saw you before, I know you. I don't know you. All right? Okay? Excretion. Okay? Goodbye forever. Secretion is something that you can eliminate, but depends if you need it, you're going to reabsorb again. Okay? So it's a combination of depends what is convenient for me. I'm going to eliminate or I'm going to reabsorb. For example, we have here, this is the blood, and we have, this is the blood, and the blood we have too much hydrogens. So that means my blood is acid. So that means my blood is less than 7.35. So I have excess of hydrogens. Okay? If I have excess of hydrogens, what I'm going to do is the kidney is going to secrete, eliminate the hydrogens through the kidney. Okay? But if my pH of my blood is too low, pH less than 7, more than 735, so I have hydrogens here, and hydrogens that are being eliminated. So I need acid because my blood is alkaline. So what is doing the blood? Instead to eliminate the hydrogens, they are going to reabsorb the hydrogens. Is that clear or no?
Yeah.
So that is going to reabsorb. So that depends on what I need. If my blood is too alkaline, I need to reabsorb hydrogens. But if my blood is too acid, I need to eliminate the hydrogens. Okay? The same thing happened with the bicarbonate. For example, if my blood is less than 735, right? It's too acid, I'm going to eliminate hydrogens, but I need to absorb bicarbonate. Remember in the first lectures, I was telling you bicarbonate is what is making the pH very alkaline. So that's why the pancreatic juice have bicarbonate, make this pH very alkaline. So I want to keep my pH of my body between 735 to 745. If there is too much alkaline, that means I have too much bicarbonate. So what I'm going to do? I'm going to eliminate the bicarbonate. But at the same time, if my blood is alkaline, that I already told you has too much bicarbonate, probably I can tell that I have too little hydrogen. So in order to keep my pH in normal balance, if this is alkaline, are going to eliminate bicarbonate and are going to absorb hydrogen. On the other hand, if I have my blood too acid, I'm going to eliminate hydrogens, but are going to reabsorb bicarbonate. You okay with that?
Yes.
Okay. Don't tell me yes, because yes, I want you to understand. All right. Number 5 is going to be hormones. These hormones are going to be 3 of them. One is the renin. Talking about the renin is very important. Renin is going to increase the production of aldosterone. What is doing the aldosterone? Aldosterone is going to reabsorb sodium. If that is going to reabsorb sodium, the reabsorption of sodium are going to pull water, bring water to, because the water is going to follow sodium. Correct? Remember the cardiac output and all that, right? So the renin, listen to this, the renin is going to produce by the kidney. Renin. Then the renin go to the liver, where it's going to produce the angiotensin 1. This angiotensin 1 are going to go to the lungs. To produce the angiotensin 2. This angiotensin 2 are going to go to the adrenal gland. This angiotensin 2 are going to go to the adrenal gland, and the adrenal gland produce aldosterone. The aldosterone reabsorbs sodium, the aldosterone go to the kidney, and the kidney, what is going to do is to reabsorb sodium. This reabsorption of sodium, pull water, means that the cardiac output is going up. Your blood pressure go up. So if you see here, you must know this. Kidney produce renin, 1. The renin in the liver produce angiotensin 1, 2. Then they go to the lungs, angiotensin 2. Then the angiotensin 2 go to the adrenal gland. That is the adrenal gland 4 that produce aldosterone. And the aldosterone are going to be produced by the adrenal gland, and the aldosterone go to the kidney, and the kidney is going to reabsorb sodium. That system is called the RAS. The renin, angiotensin, aldosterone system. This is crucial, important. Why? Because you can control blood pressure. If, for example, so who is going to increase the blood pressure? Is the aldosterone. If you cut one of the cascade of reactions in this area, aldosterone is not going to be produced. If you have low aldosterone, you don't reabsorb sodium, so you don't bring more water into your vascular space, so your cardiac output go down and your blood pressure go down. In pharmacology, what is coming, just to show you, there are going to be medications who are going to block the renin. Other medications are going to block the angiotensin 1. Other medications are going to block the angiotensin 2. Other medications are going to block the aldosterone. If you block in any of these steps of this cascade, the aldosterone is going to be decreased. And that is going to control the blood pressure. We okay with that?
Yes.
Yes.
Okay. So that is one of the functions of the renin, of the hormones. The other hormone that you need to remember is the erythropoietin. Erythropoietin. The erythropoietin, erythro red blood cells. Erythropoietin go from the kidneys, they go to the bones. The kidneys is going to produce the erythropoietin, and they go to the red bone marrow to produce more red blood cells. I said red blood cells, erythropoietin. Don't get confused with the hematopoiesis. Hematopoiesis is red blood cells, the erythropoiesis. We have the production of white cells and the platelets. This erythropoietin is going to affect only the erythropoiesis, only the production of red blood cells. Is that clear or not?
Yes.
So, do you know somebody with kidney failure? Do you saw somebody, patient, kidney failure? Somebody?
No.
Not yet? You will see that the patient with kidney failure are going to be, her face is very pale, very pale. Why is pale? Because they are anemic. And why they are anemic? Because the kidney is not working. And that means that they do not produce erythropoietin to stimulate the production of red blood cells. So that's why they have low red blood cells, and patients with kidney failure, look at the face, it's going to be pale because anemia. You okay with that?
Yes.
And the last thing for hormones is the production of vitamin D. Sorry, activation of vitamin D. What is the vitamin D? The vitamin D, we have two sources. One source is the skin with the sunlight. The sunlight on the skin make your body produce vitamin D. The other source of vitamin D will be your diet, your leaf, your chard, your etc., right? Spinach, and that is going to be a source of vitamin D. This vitamin D then is absorbed and go to the bloodstream. In the skin, vitamin D is formed and absorbed into the bloodstream. So you have two sources of vitamin D. What is the function of the vitamin D? The function of the vitamin D is to absorb calcium. Absorb calcium. Remember the rickets and the osteomalacia? All right, so that is bioscience. So vitamin D. But this vitamin D that coming from your diet and from your skin, running into your blood is not working. It's not working. It's not working yet. It's not working. The vitamin D that is in the bloodstream by diet and the production of vitamin D in the skin is not working. It's not working. So when is going to be working? It's going to work when they pass through the kidney. The kidney is the one who activates the vitamin D. The kidney do not produce vitamin D. The kidney produce the activation of the vitamin D. You okay with that?
Yes.
Okay. So that is perfect. So just remember that, please. So how to remember this mnemonic?
Red.
Fresh red. Yes or no?
Yes.
Yeah.
Give me an F.
Filtration.
Give me an R.
Reabsorption.
Give me the E.
Excretion.
Excretion.
Give me the S.
Secretion.
Give me the H.
Hormone.
Give me the R.
Renin.
Give me the E.
Erythropoietin.
And give me the D.
Vitamin D activation.
Activation of vitamin D.
What's that spell?
Okay? Fresh red. You will not find in any textbook, in any video, anything this mnemonic. So don't share with anybody, just for you. So when they'll say, what are the functions of the kidney? Filtration, reabsorption, excretion, secretion, hormone, renin, erythropoietin, activation of vitamin D. Nice? Yes or no?
Yes.
Okay. Now, let's go over the physiology. What time is it, please?
125.
Okay. Give me 5 minutes, please. This is the last portion. Okay? The physiology. Okay. Tell me, how many times you go to pee? Basically 10 to 12 times a day. All right, so you need to remember that polyuria. Polyuria is a normality. You pee more than 12 times a day. That is polyuria. So basically, you're going to pee about every 2 hours. Okay? All right. So now, normal. So now, we have here that the kidneys are going to receive, both kidneys are going to have 650 mLs of blood per minute. So it's like, for the kidney, it's going to run about 1 bottle of wine every minute in both kidneys. No 650, no, total. For both kidneys, the total, 650. We okay with that?
Yes.
Now, from these 650 mLs per minute that is running into the kidneys, what is the filtration? The filtration means everything that is passing from the glomerulus to the proximal convolute tubule. That filtration is going to be 120 mLs per minute. That is the filtration. Okay? So from all this bottle of wine, the filtration, what is happening is passing through the kidneys, through the convolute tubules, are going to be half of a cup of coffee. Can you imagine that? From the whole bottle, what is going to go through the convolute tubules is 1/2 of a cup of coffee, 120 mLs. You okay with that?
Yes.
Yes.
From these 120 mLs, they are going to reabsorb, they're going to reabsorb 118 mLs per minute. How much is that in percentage? %98 are going to be reabsorbed. 98%. 98%. From this 90%, so 118 mLs reabsorbed from 120, that means that the rest, the 2 mLs, 120 minus 118 is 2 mLs, yes or no? Right?
Yes.
Yes.
And that 2 mLs, the difference, 2 mLs per minute is going to be excreted. That excretion is the urine. So that means that you are going to produce about 40 drops of urine every minute. Okay?
Yes.
Okay, and the last thing. The urinary bladder are going to this is the urinary bladder, are going to receive the ureters. The urinary bladder are going to have a capacity about 800 cc to 1,200 mLs. So it's like one bottle of wine, about. That is what your capacity of the urinary bladder. Urinary bladder is about 6 centimeters long. So it's like this. Look at this. Oh, you don't see my screen. Oh my God. Sorry. I finished. Why didn't you see the camera? Okay. All right. So the urinary bladder is going to be 6 centimeters, like this. This is 6 centimeters. Look at that. That is very tiny. Okay, it's going to be distended. This urinary bladder are going to be similar as, remember the heart? The heart, when it's distended, contract harder, right? Like a rubber band. Another rubber band we saw is in the rectum. The more distended, you have defecation. Now, when you feel the sensation to go to pee, you're going to feel the sensation because the urinary bladder is going to have this same reflex, that when more distended, they're like a rubber band, they're going to try to come back stronger. And that is what? That is the sense when you have the sensation of to go to pee. How much volume you have in order to have that sensation? 400 cc or 400 mLs is the same. 400 is the half of the bottle of wine. So that is the moment that you feel the sensation. The muscle who are going to be composing the urinary bladder is going to be called the detrusor muscle. Detrusor muscle. That detrusor muscle is the one who make the contraction of the urinary bladder. Okay, all right. And one more thing. This is a smooth muscle. Is an involuntary muscle, so you cannot have control of that. But how come you can stop your urine? You stop the urine because the urethra that's coming here, we have an sphincter. This is the urethra. The transition between the urinary bladder and the urethra is going to have an sphincter. This sphincter is a striate muscle. We have two sphincters, but anyhow, striate muscle. That is a skeletal muscle or voluntary muscle. So that's why you can retain the urine when you wish. Okay, we okay with that?
Yes.
Okay. And now the last thing, this is the few words. We have the laboratory test. The laboratory test is going to be this one. The laboratory test for kidney profile. Kidney profile. The kidney profile is the laboratory test that you use to know how is the kidney working. And for that, you're going to check, it's a blood test. It's a blood test. It's not a urinary test. It's a blood test. That you're going to check the levels of sodium. You're going to check the levels of potassium. You're going to check the levels of chloride. You're going to check the levels of bicarbonate. You're going to check the BUN. BUN is the blood urea nitrogen. That is the urea. And we have the creatinine. And the last is the glucose. So we have 1, 2, 3, 4, 5, 6, 7. That is what we call Chem 7. Chem 7. Chem 7. That is the kidney profile. That is what we call the fish skeleton. Okay?
Yes.
Yes.
Okay, guys, thank you so much. Thank you for your patience. All right, any question, please?